Oh, hi.
I had a question about how you felt about idebenone and if there was anything. Can you hear me? Sorry. Idebenone and maybe for those who can't get onto the trial, if they used it under compassionate use. Is there something, does it affect steroids at all, or is it something where you would have to adjust medication if you were trying that?
So thank you for the question. The question is about idebenone, if that interacts with steroids. Is that correct? Whether idebenone interacts with steroids. So idebenone is a synthetic CoQ10 that is currently in a clinical trial. The previous trial for patients not on steroids demonstrated benefit on pulmonary function. So there's an ongoing trial right now for patients on steroids. And there is a compassionate use program for patients who do not qualify, who do not meet the criteria for the trial. As far as I know, we know of no drug-to-drug interaction between CoQ10 and steroids, and so I'm not aware of any between idebenone and steroids. And it's been done in the trials in kids on steroids right now, and we have no reports of any drug-to-drug interaction.
Question. Hi, my question is for Emily. Sometimes when we use the cough assist machine, when Jake is breathing out, he yells into the mask. Is that okay? I'm just asking.
Okay. I think anything that is working with the cough assist to get air out. So if you're yelling, I think it just might be like a natural kind of happening. But he's moving air out. I would encourage him to grunt or huff there, and that kind of, if you use that deep breath and kind of work it out a little bit more, you'll get more bang for your buck when you do your cough assist.
Would you like to demonstrate?
I actually have a question.
Okay.
I apologize if I missed it earlier, but did you say at what age you start teaching the breath stacking and then actually prescribe the cough assist?
So breath stacking and cough assist require putting together a series of instructions, just like doing the pulmonary function testing. So I kind of lump it into the kind of middle childhood, starting around age 5 to 8. It really depends on when we first meet the boy, and then when he's able to kind of coordinate it all. But we can start practicing earlier, but the older you are, the better you'll be able to coordinate all those series of instructions and making your body do the effort that we're asking it to do.
Cough assist is actually more based upon your pulmonary function. So you're not going to, it's not prescribed until you're really kind of at a point where lung function is, and we talked about or Emily talked about the cough peak flow, which is one of the function tests that is done in clinic. When you see the strength of the cough that is becoming a little weaker, when it reaches a certain point, then insurance will actually allow you to then order this and begin to use it. You might be able to justify it if there's also concerns with just if the parent, the individual is describing more difficulties in just clearing mucus when they have a cold. So there's maybe justification that you can use with that too. But typically the pulmonary functions help.
So, hi, I have a question. It's Deborah. First of all, Dr. Wong and the whole team, I'm just so impressed and blown away by how complete you are and just the dedication you have to our boys with Duchenne. So thank you very much. Question for Mike. So we fought really hard to get all the bells and whistles on our F5, and including the stander, and he can't use the stander because it hits him at the wrong place. Is this something that is adjustable? But I've heard this from several boys, and he's not able to use it.
Yes,
Am I? Yeah, I'm still. Okay, so that is a great question, and we have had a lot of families have difficulty with the standing function on their F5s. You're still at a little bit of hip flexion and knee flexion when you're using that stander. I talked with a peripheral rep actually last week. We met with them, and they said that some of the seat back, seat depth functions on that may adjust that a little bit. And there are some other options about maybe bringing the knee block closer to you, so you're in a little better knee extension. And then maybe not as adjusting as much for plantar flexion, so that you're getting more flat foot weight bearing instead of kind of sliding forward into the knee pads. But I assume you're talking about maybe pain in the front of the knees, or is it just? Yeah, and another option would be loosening those knee pads so that they swivel. I've had some patients come in where they're only making contact on the top of the knee there, and not getting full contact with the pad or adding some padding. But that has been something that's been brought up a lot. I think that the technology keeps getting better, and I would like to see the permobiles go straight up and down, exactly.
CYA.
I have a pulmonology question. I guess it's two-part. How do you know when the cough assist settings are no longer the right settings? Like, what would be the complaints? And the second one would be, we've had a BiPAP for like a year and a half, never used. He just can't find the right mask, or there's just something, it's like one thing after another. So what would you do to kind of encourage, or would you have a respiratory therapist? I mean, how do you, I mean, the hour watching TV and wearing it to become accustomed, or just having the mask on, none of those things have worked. And so it's just a nice machine sitting on the bedside table.
They work as doorstops pretty well, too. But I'll start with it.
Yeah.
Okay. So, I think in regards to the cough assist and the pressure, part of it is just how comfortable it feels to the individual who's using it. You'll see pressures, so you'll hear the numbers. I mean, the low pressure that we start with is maybe around 20, and it may go up to 40 in terms of where we go. But most are probably going to have pressures that are around 30 to 35. But when you're younger, definitely, if you have this when you're, kind of early teens, you're probably talking probably 25-ish to 30. 20? Is that right? How low do you go?
I think it's like, I want to say like 11 is one of the settings. I mean, it's more
Mo- You can go pretty. You can go to certain levels that are even below what I'm saying. But usually, you're kind of talking a low of around 20. But if someone truly has a hard time with even that, it's better to start somewhere to help them to get comfortable using it. And even if it means it's at 15, I'm going to say 15. It's better to start somewhere that you help them to get used to it, and then as they can go higher, then trying to kind of encourage and push for more. But I would definitely say over time you do want to try to push higher as they are able to tolerate a little bit of a higher pressure. So I mean it doesn't mean doing it over the course of days or weeks. I mean this can take months to a year or more to get there. So it's just kind of more of a tolerance in how far each individual child can go or boy can go. So, with BiPAP, it's not simple for some of our patients, whether you have Duchenne's or you're just using it for other reasons too. A lot of it comes down to, getting over that hump and just kind of making that decision that you're going to use it. We actually often will say, let's start with even doing it when you're awake during the day so that you can just kind of get comfortable with having the mask on, with the pressure going through it, and how it feels with just normal, natural breathing. Having them playing video games, I mean, they like their phone. I mean, everyone likes their phones. Everyone likes whatever. I mean, doing it while they're doing something fun so that they can kind of associate it with that. And so that's one way to try to encourage is to, do it when they're awake, in the evening hours before bed, playing video games on the phone, on the iPad, whatever. Hopefully not like using the iPad right up to bed so that their circadian rhythm gets all messed up and they don't sleep because of that, but that's a whole other story. But, continuing just to encourage the use of it, as well as, getting them to get the right mask. And sometimes, the sleep study indicates needing a pressure that is at a certain level that seems maybe high, and maybe we need to start a little lower. So if they're having a difficult time, we may have to just adjust the pressures down a little bit to help them become more comfortable with it, with a goal then of working up over time too. So the stomach sleeping is definitely not as easy when you're using BiPAP for sure. There's not a simple answer for that one other than trying to encourage learning to sleep on one side or towards one's back, but you kind of have to identify other positions. You can wear it on your stomach, it's just not quite as easy with your head, especially if it's in the pillow.
So I deal a lot in the regular clinic with the BiPAP compliance and the CPAP compliance patients with non-Duchenne's patients. And the times when we've struggled for years. I think one boy was 6 years, another girl was like 4 years before they're fully compliant. And it's, persistence and, but also making sure that there's a whole team that's involved. And I think the more people that are supporting the person or the child to use it successfully, whether there's a school counselor, there's a behavior plan, getting as many people involved to support them in a positive way really makes a big difference. And then lastly, I do find that when they're struggling, making sure the whole emotional picture is in good shape. Sometimes when things feel out of control and you're lying in bed trying to go to sleep and something's pushing air into you, it really makes things worse. So making sure that we're feeling well emotionally, in a good spot to try this with all those supports too. Maybe then we can get forward.
Hi, Tammy again. I had a question about contractures, and it's keeping or preventing my son from sleeping. And I was wondering if you guys have experience with kids who have had the lengthening surgeries in their hip flexors and their knees.
It's kind of rare to have release for the hip flexors. They are very deep, and that surgery is associated with a lot of pain. So we have not done the hip flexor releases. We have done more of heel cord releases with hamstring releases for some of the older kids, but it really recurs back really fast if there's not positioning and stretching to maintain the range. So I think in terms of surgery for release of contractures, I would say we have learned that there's a group that really benefits with the heel cord releases to get them back down on their feet again, and that really helps, I think, prolong the walking ability as well. The hamstring releases for the knees, I see that recur really quickly, even 6 months to a year after.
Oh, wow.
Yeah,
Wow.
because it's really at that stage, contractures are positional. And if we are sitting with a lot of knee flexion the whole day, you just can't keep that extended.
So it's really not worth the
I think
pain that they
it
would
has
go
to
through.
be, if each patient has to be evaluated by the PT, the neuromuscular doc who is kind of familiar with it, together with the orthopedics. We usually do it with three of us and the physiatrist the last time we were there, but certainly through the years we've identified the group that benefits most from heel cord releases for prolonging walking or improving the ability to stand and tolerate the stander without pain. So there has to be a functional gain, and we do not just release for just increasing range, because it will recur again.
Mm-hmm. Okay. And one more thing for Michael. So we got our chair just last year, and this is something that I just found out. They don't do crash tests on power chairs that are under 16-inch seats. My son is young, he's 9, so... And so on the school bus, they just passed a law in New Jersey where they won't allow him to sit in his power chair on the school bus. So what we have to do, I had to get a special waiver so that I can get on the bus, take him out of his seat, and put him in a regular school bus seat. And I'm finding that there's a lot of people that are starting, like a lot of school districts that are starting to demand this, and I just don't understand why wouldn't they, or I was hoping that maybe someone could talk to these companies and say, hey, listen, can you crash test the smaller chairs? I mean, why wouldn't they? It doesn't make any sense, So from what they say, no chair out there is crash tested under that size. So.
Are you talking about a manual chair or a power chair?
Power chair.
Power chair.
Yeah.
So I don't know the specifics about the crash test regulations, and that's another piece where I think it's really important that we specifically involve like an equipment rep. So contacting your company and saying, is there any literature about the safety of these? And if not, giving them that feedback that maybe that's something that's important, because a lot of families are using them to get back and forth to school, and it's not very helpful if we have to do transfers in and out of them.
Yeah.
Just an aside, safety in general with chairs, please always wear your seatbelts. And 2, seatbelts on your chairs are not seatbelts in the car. You still need to use a car safety seatbelt, one that is in the car, even if you are in your chair and harnessed down into the chair with the ties. So I wonder if it's a situation where potentially your school bus or district could have something where there are tie downs and like a regular seatbelt as an option, like you would in a car or a modified van.
Well, what it was there's a specific, I guess, number that they give for the crash test. I guess I'm not sure exactly what they call it, but legally, it has nothing to do with. In fact, when we contacted the manufacturer, they, in the paperwork, and they told me themselves that it is not intended to be ridden in an automobile. Which
Okay.
I was like, what? Well, how many other people are supposed to? So basically, they're saying we all have to take them out of their seat, put them in a regular car seat, even we have the whole package, like the tie downs, the harness,
Yeah.
everything. But in the paperwork, if you read carefully, it says not intended to be sat in a vehicle.
Yeah, and to be honest with you, I haven't had a lot of experience directly with that, but I think I saw either people from New Motion and or Permobile and maybe some other vendors here. It's probably a great thing for us to kind of go discuss with them. Are they here tomorrow as well, or still now?
Okay, great.
Because I think that's one of the things where we want to loop everyone in.
Yeah,
they're the
it's
experts in it.
kind of new, in New Jersey, so I think it might start
It'll-
spreading.
it'll
and
be spreading,
people are
I'm
going to
sure.
be,
Yeah.
stuck.
Absolutely.
I just wanted to respond to the hip flexor question that you had. So Ben had hip flexor tendon releases, and he would tell you it was the worst surgery he ever had. I mean, worse than spinal fusion. And it really, like Dr. Wong said, had no real benefit in the end. And I would say that the thing that we have learned best to prevent contractures or prolong flexibility is just consistent use of AFOs during the day and knee immobilizers at night. My guys are still able to wear regular shoes, where a lot of kids their age, their feet have contracted. So just keep them in their AFOs and their knee immobilizers at night, and I think that'll be really helpful. Knee immobilizer? So I don't know, maybe Mike can talk about it, but we had knee immobilizers, and then we also had some casting done.
So there are a couple options for knee contractures. There is stretching. There are custom braces. So Benick makes something, I think it's called like the KI 1000 or something, and there's PD wraps, which are non-specific. But it's basically goes from ankle to hip. and you can set it custom to the amount of range of motion that you have. And the goal is similar to the ankle orthotics that we use, to keep you in a comfortable end range position overnight so you get a real gentle stretch overnight and try to prevent further tightness behind that knee. And then the other thing which you may be referring to is they also do something similar to serial casting like they would at the ankle, where instead of applying repeat casts every year, or every week, they'll cast your knee and then add increased wedging to basically make that knee cast a little straighter every week. I haven't had a lot of patients have serial casting at their knee, but I do know that that's used in some other patient populations, so that might be kind of the casting that you were referring to. It wasn't serial, it's just one cast. And redo, okay. So yeah. Yeah. And again, I don't know about the effectiveness of serial casting at the knee. Dr. Wong?
I'm always proactive, and so I think basically we advise a lot of L sitting, where, when we are sitting a lot in a wheelchair the whole day with 90 degrees of knee flexion. But that's why the leg elevators, where you have that, and you're going to stretch out those hamstrings, that really, it's very helpful. Rather than having the knee mobilizers at night will help them extend it. The British call it the knee gaiters, and basically it's very cheap. It's a piece of canvas with strips of iron in there, and then they just wrap it around that knee, and so with those iron strips in there, you cannot bend the knee. Yep. And you saw the picture in the slides where you can actually get the patient who's non-ambulatory, non-standing, into a standing position and starts taking steps. So it's really getting that knee extended. Any knee flexion is not tolerated. You lose your stand stability, you lose your gait stability with some degree of knee flexion. So we always talk a lot about L sitting.
And one other thing, I think it's great to do that stuff during the day, because at the same time we're talking about getting 9 hours of sleep at night, we also have a BiPAP and ankle orthotics and 2 knee orthotics and hand orthotics, and how are we going to sleep that way, right? So if we can build things into your daily routine without disrupting your sleep and academic, all that stuff, I think that's really important.
I have a nutrition question. Over here, sorry. My son is 17. He has an anaphylactic dairy allergy and will not go near any rice milk, almond milk, anything like that. So we've always had to give him supplementation, but what foods do you recommend that are very high in calcium that we could use to try to get through his natural diet?
It's a great question. So dairy is a very efficient means. Usually when I go through food sources, like a cup of yogurt or a cup of milk is 300 versus a half a cup of broccoli might be 75 milligrams, for example. So almonds, I usually push if he is including tree nuts. No tree nuts. Okay. Broccoli. There are sources. I have a whole, there are non-dairy sources that kind of walk you through, but I think in that case, yeah.
Tofu.
She's shouting tofu.
Sardines.
Do I really need to go there? Oh, I'm a very realistic dietitian. If he loves tofu, then that's an easy one.
He loves broccoli.
Okay, well, right. But unfortunately, you can't consume 1,500 milligrams of broccoli in a day. So I think for him, you're definitely looking at supplementation. But yes, there are other sources. I would probably say, generally speaking, throughout your whole day, you're going to get a couple 100 milligrams just from food summatively happening. But rich sources, off the top of my head, I mean, does he do calcium fortified orange juice?
It affects his reflux.
Yeah. So usually the orange juice is out for several reasons: blood sugar, reflux, yada yada. So in that case, yeah, I think the supplementation is going to be a key, but certainly you can look up some other ideas of where you can get things that are maybe around 100 or so milligrams, 150, and that will help to kind of add up a bit and supplement the calcium fortification.
Thank you.
You're welcome.
And
Yeah, for the constipation, you said something about fresh apple and
Yes.
banana.
yes.
So I was thinking whether we should continue to give him, my son, like a smoothie, because we use a fresh apple every day in his smoothie. So I was thinking,
But
if
he's not constipated,
Yeah,
right?
if he's constipated, then I would recommend replacing the apples with either berries or one of those other fruits that starts with P, so plums or
does.
peaches, things like that, as opposed to the fresh apples. But if he's not having issues with constipation and he's having one apple a day, that would be perfectly fine.
okay.
Hi guys, I just wanted to thank you all for coming here, especially Brenda and your team. You guys are all angels to us, and from the bottom of my heart, I just want to thank you all, and you guys have been so great. So, thank you.
Thanks, Hawken.
Hi, it's kind of a question for Courtney, maybe pooping question.
Bring it on.
Just getting your thoughts. I mean, I try to get fiber in, but your thoughts on fiber supplements?
Honestly, in our population, they can actually make things worse. As long as there's enough fiber in the diet, then we really don't recommend fiber supplements for the treatment of constipation in a patient with Duchenne, because it actually can bulk up the stool more and make it harder to pass. So getting fiber in your diet is great, and Jen could give you guidelines for fiber for the boys' ages, but in general, we don't recommend adding fiber as a supplement if they're getting adequate fiber in their diet.
Okay, thanks.
Hi. I have a question about cleaning the respiratory equipment, the BiPAP and the cough assist. I'm not sure how much to clean it, or if it's clean after I cleaned it.
Am I on? It's a big debate. So some people are cleaning every use. You can do a simple rinse and air dry, but at least once a week. It depends on what equipment, but if it's like a BiPAP mask or the tubing, you can soapy water rinse. However you're comfortable, but at least once a week. Sometimes I have the kids just go right, if they're morning bathers, go right into the shower with it, clean it in the shower and hang it up in the shower and let it dry, and then you put it back on during the daytime. I do recommend doing the maximal amount that your insurance allows for mask changes and tubing changes and filter changes. The filters often get forgotten, so that's a big one. If it's for the cough assist, you really do want to do the maximal, especially for the filters, because if you do have those aha moments, the machine gets full of goobers and you really want to clean it out well. We don't see a lot of people having respiratory infections from the equipment. So I think what you're doing is probably okay, but I'll tell you, there are people who do it every day and people who never do it, and I don't see anything in between. So it's whatever works for anyone, just as long as you do it maybe once a week.
And if there's mucus in the tubing, then I would clean it daily if it's happening daily.
But on the BiPAP, the mucus doesn't get into the tubing, right? It could it not?
No, it's gonna be most likely in the mask.
In the mask.
It can, but it's not as likely. So
Because commercially, I see a commercial on TV about sanitizing your BiPAP every night, and should I buy one of those, or is that just a gimmick?
I think it's probably more of a gimmick.
Okay.
And when you get a new mask, which some insurance allow it every 3 months, 6 months, and get it as frequent as it's typically allowed, and don't throw away the old masks in case one of them breaks and you have another one to go back to. Make sure it's clean then when you store it.
Oh, okay. I've been meaning to ask Mike about this. How do you clean a wheelchair? Like seriously, you almost need like an air gun or something to get into all the areas.
I assume you're talking about more than just like the seat cushion cover and stuff like that, right?
That is correct. I do have OCD.
This is the first time I've had this question, but I think you are on the right track, maybe with one of those air guns. If you get, those little desktop cleaners, I bet that could knock a little bit of dust out there. I would not recommend garden hosing it. Okay.
Can I do it with him in it though? Because that would be fun.
Yeah, one of the computer cans might blow some of the dust out of there.
Yeah, the air can.
I don't know. Q-tips, wipes.
Okay, one last poop question. So, for a friend. So tell me, how do you decide if there's a lot of loose stools, whether it's medication, food, or going through? How do you start breaking down to correct it to more typical?
Do you want to take that one, or do you want me?
I don't quite get it.
So if a child is having a lot of loose bowel movements rather than constipation, how do you decide if it's one of their medications? If it's one of their medications causing it, or if it's food causing, like a certain food causing it, or what? How do you break it down to,
So probably a review of the medications that's recently started, and those that's known to cause diarrhea will be what we would kind of ask the history. The other one is, of course, knowing if there is a history of constipation. If there's no history of constipation and there's diarrhea, whether it's infectious, and that's one thing, is that whether there is a gastroenteritis, that's something we would want to rule out. Spurious diarrhea is when we know that there is a history of constipation, and there's always the big stools or the hard stools and the consistency of stools, and it's like a little bit of spurious diarrhea, and then the thing is that we suspect that an X-ray will show the amount of stool load and the amount of stools that's in there. So we usually would have that confirmed on the abdominal X-ray and be very confident that that was that spurious diarrhea because of all the stools in there.
And physical examination as well. I mean, just having the patient be seen so that they could get the X-ray. We could do the physical exam, palpate the abdomen, see if there is a mass of stool that's easily felt, and then that we could see on an X-ray. That would give us some information.
Just one more thing to add. I don't know if this one's on. To keep when the episodes occur, to go backtrack of what foods were eaten and keep a log of those foods to look for some food associations. To see if you can find any correlation with the diet.
I think it's sauces, acidic stuff, like red sauces and spicy.
Yeah, and sometimes it's
sauces.
Atypical things. It could be something really funky and fluky, and maybe we can work out exactly what that is. Is it lactose intolerance? Is it an allergy? Is it a gluten thing, or whatever the case may be? But usually, if there's something weird gastro-wise going on, and we're trying to see if there's any food triggers, I like for the episodes to be recorded in correlation with what they had eaten that day, preceding the night before, or whatever.
I had a question for Dr. Fahey, changing the topic totally. First, how common are abnormal EKGs in cardiology in Duchenne? And then another question is, with some of the cardiac medications, are there any side effects we should be concerned about over the long term, like any vitamin deficiencies or any long-term side effects from all those medications? And also just nutritionally, is there anything that you look at from a cardiac perspective?
Sure, so I'll try to take those one at a time. The first question was, remind me the first question.
Yeah, abnormal EKGs.
Thank you, abnormal EKGs. So abnormal EKGs are seen very frequently in kids with Duchenne's for reasons that we don't totally understand. And in fact, the abnormalities that we typically see are of ventricular hypertrophy, seeing voltages, electrical signals that are actually bigger than you would expect for somebody. I'm not exactly sure why that is, but it doesn't seem to be a pathologic problem. That is, it's an abnormality, but it's not a clinically relevant abnormality. Getting into more significant cardiac problems like arrhythmias, thankfully arrhythmias are quite uncommon in Duchenne's muscular dystrophy until somebody develops a great deal of heart dysfunction, and then arrhythmia can be a problem. But thankfully that's not usually a problem for the majority of the time. With respect to, I think the second question was about long-term side effects of medications. Long-term side effects of medications, thankfully, most of the medicines that we use are very safe. The main, for example, ACE inhibitors are probably the most common medications that we use. And as long as you're keeping an eye on kidney function and the patient staying well hydrated to kind of keep those kidneys not thirsty, they're very well tolerated medicines, with the occasional person who develops that annoying dry cough, in which case we oftentimes switch them over to an angiotensin receptor blocker. And that cough, by the way, is it's not a dangerous problem, it's just an annoying problem. So as long as you're keeping an eye on electrolytes, we don't really think of these medicines as being harmful in the long term in any significant way. Brenda was just saying, and this goes for any medication. You always have to be aware of any kind of medication interactions if your child has to go on to another medication. So for example, they're sick, they go on some sort of antibiotic. It's always worthwhile either to check with one of us or to check with the pharmacist to say, hey, my son is on X, Y, and Z medications. Are there any interactions? And Dr. Wong was just mentioning, with ACE inhibitors, Bactrim is kind of a no-no. And there's examples of that with a lot of different medications. So it always makes sense just in general to run your medication list by a pharmacist or by one of us, and we can try to help you figure out if there's any cross-reactivity there. And then the last question, I believe, was any nutrition advice. Logical stuff, heart healthy diet. There's nothing, I wouldn't say, go out and, have 10 grams of omega fatty acids a day. We don't have a lot of great information about that, but heart healthy diet, the common sense things.
Thank you.
Welcome.
And thank you for all coming out on a Saturday.
I'm going to ask one more quick question along that track about, I had this cough recently, and I had a doctor at the USC Medical Center prescribe me Mucinex, and then I found out that apparently that interferes with some of the cardiac medications. And I was wondering if you could speak to kind of the importance of, knowing the different interactions.
Yeah, thanks for that. So a lot of these, a lot of kind of over-the-counter type of stuff like Mucinex or other decongestants, a lot of decongestants have a stimulant type or adrenergic type medications buried in them, like kind of adrenaline-related chemicals, okay? So Sudafed, for example, and other decongestants. One of the ways that a lot of these decongestants work is they cause blood vessel contraction to kind of open up the airways. And those medicines, while I wouldn't say they're necessarily dangerous in folks with Duchenne's muscular dystrophy, they're definitely not an ideal thing to be taking on a regular basis. So I think if you were really very ill with a cold and you're really having trouble breathing, you can't sleep because you're so congested, I still wouldn't be crazy about you taking one of those medications, but I also don't think that you would be doing something really, really harmful to yourself either.
I'm going to comment on it. Is this
on? I'm not sure if it's on.
Can you guys hear me? Yeah. Okay. So, in general, these over-the-counter cough medications, there's not a lot of data that they work either. So, unrelated to the question for heart and whatever else, the data doesn't necessarily support that they do a whole lot. So, I think you're much better with more natural type remedies. Drinking plenty of fluids, saline sprays for the nose, and different types of just kind of natural-based kind of therapies. And your cough assist and other things that we try to encourage. So, in pediatrics, we actually truly discourage a lot of the over-the-counter medicines because of just other risks that can happen in regards to cardiac function and stuff.
Okay, well, with the lull, I'm gonna, it's gonna feedback. I'm gonna stop us right there because it is time for our next event. But if any of you are able to stick around and all, please search them out if they're here. We're going to have beverages and meals in the room just down the hall in just a minute. But I want to thank you all so much for giving us your time and your knowledge.